presentation for us very, very soon. The event today is going to be recorded, so just making you aware of that prior to us starting. But I'm also delighted to say that we are joined by people from members of the healthcare community from South Africa, from the US, and people from the Nordics, and also our wonderful NHS and private hospitals in the UK. We've got people from sustainability aspects, and we also have people from other commercial companies too, and you're all very, very welcome. During the chat and during Michael's presentation, please post any questions you have into the chat box, whether they're directed to Michael for infection control or myself or Rasheen about TriMedika. Please feel free to do that and we'll address them at the end of the presentation. But without further ado, I'm going to hand you over to Michael. So enjoy the presentation, post your questions in the chat box and enjoy. Thank you, Michael. Good afternoon.
Just going to share my screen and turn my camera off for the presentation. So I'm just going to sort that out now, and then I shall make a start.
Fantastic. Thank you, Michael.
So hopefully you should be able to see my presentation on the screen now.
I can see it in the UK. Can everybody else see it?
Okay, so thank you very much, first of all, for asking me to join this webinar today and to do this presentation. As Andy said, my name is Michael Neville. I'm an infection control specialist nurse. I have worked in the NHS and the independent sector and the charitable sector as an infection control specialist nurse and as director of infection prevention and control, helping to lead organisations with their infection prevention work. So I'm first going to talk to you about why I went into infection prevention and control. And this was really about making a difference. I could really see that good infection prevention and control could really make a difference to patient outcomes. I could think about the sort of quality of care that I was expecting for myself or my friends or relatives, whether they were in hospital. And when I'm doing infection control training, I often say to people, with infection prevention practice, think about the quality of care that you would expect for yourself or your friends or your relatives were they in hospital. So you would be expecting healthcare workers to decontaminate their hands, for example, before they provided any care to you. You would expect medical equipment to be single use or decontaminated appropriately before it was used on you. And I think that that's really important to remember, that sort of human aspect to infection prevention and control. It's about the quality of care you would expect for yourself if you were in hospital. All of this leads to patient safety, better patient outcomes, minimising the risk of healthcare associated infections to patients, but it's also about staff safety. I'm really keen when talking about infection prevention that we also talk about the risk of infection to staff and why it's important to have appropriate PPE and appropriate practices to help prevent staff getting infections whilst they're carrying out their daily work. So for me, infection prevention is just as important to patients as it is to our staff and visitors to hospitals. I hope that you can understand that good infection prevention is good for patients. This is because it means that care is safe, evidence-based, and patients have better outcomes and minimising the risk of infection. So all of this does help to save money, which is in quite short supply at the moment, particularly within the NHS in the UK and England. It improves bed space. It means we can get people out of hospital quicker if they're not blocking beds because they've developed an infection that they've acquired whilst a part of their care. And improves patient outcomes. So patients have a better experience in hospital if we have good infection prevention and they get good outcomes after the treatment that they've received. So the aim of today is to have a short presentation and then a Q&A or discussion session. And to facilitate that, I'm now going to do a brief presentation covering some basic aspects of infection prevention. And the things that I want to cover today in this short presentation is standard precautions and transmission-based precautions, antimicrobial resistance, and the environment. And when I'm talking about the environment, I'm also talking about medical devices and equipment within a hospital. So people still get confused with terminology. And if people or healthcare staff are confused about this, then care may not be provided that is evidence-based, safe and effective. It's really easy, however, to understand the difference between standard precautions and transmission-based precautions. Of course, it's COVID that's really made us more aware of the difference, but it's actually easy. Standard precautions are things that we use routinely for every single patient. And transmission-based precautions are things that we do for a specific infection or an infectious agent, an organism, for example, based on its route of transmission. So what are standard precautions? Well, as I said, they are things that we do routinely for every patient as required. I'm not going to go into great detail about each one of these because I'm hopeful that you are well aware of them and how to put them in practice through the education that you would have received. Many people say that hand hygiene is the most important. Well, I agree, mainly because we need to do it for every client we see, but also because it's been proven that the hands of healthcare workers are the most important factor in the spread of healthcare associated infection. The list of standard precautions that I've got on here from the definition from the World Health Organization, and as you can see, it includes appropriate PPE, the appropriate use of sharps, respiratory hygiene and cough etiquette, become very, very important over the last couple of years with COVID, as has environmental cleaning, the use of linen, waste disposal, and patient care equipment. Transmission-based precautions are different because they are things that we do for specific scenarios or specific infections. These are split between contact precautions, droplet precautions, and airborne precautions. These are additional to standard precautions. So contact precautions are used to prevent and control infections that spread via direct contact with a patient or indirectly from a patient's environment, including from equipment. And for example, we'd use these for MRSA and hepatitis A. Droplet precautions are measures to prevent and control infections spread over short distances, usually no further than 1 meter. And it's usually via droplets from the respiratory tract of an individual.
I'm not sure. Has anyone else lost Michael? If you can type it in the chat box, I've lost. Looks like Michael's connection's gone down.
Yeah.
Okay. My camera is off, but I am still here. Whilst we're waiting for Michael to come back, there's been some brilliant points already raised, I think, just in that short time that Michael's been with us. There we go, just pop it on so prove I am still here. Yeah, so I'll quickly jump in whilst we're waiting for Michael. I do not have the infection prevention knowledge that he does, but he raised the point there about infection prevention saving money and improving bed space and patient outcome. And us as a company, as TriMedika, is something we're very passionate about, plus the sustainability side. Rasheen, maybe if I drop to you for a couple of minutes do you want to give everyone a bit of a background really about how TriTemp came about? I know it's not a commercial one, but I just thought in that short term, we might as well use that space until Michael returns.
Yeah, thanks, Andy. Yeah, so just for everyone's interest, TriMedika and the TriTemp thermometer came from when we identified a need in the wards and in the hospitals for non-contact thermometers, and this was specifically from an infection control point of view. We spent a lot of time talking to nurses, and actually nurses helped us to design and develop the thermometer, and their feedback based on the need for better non-contact thermometers is what led to the development of the TriTemp. And even to this day, when we're talking to the nurses in the hospitals, they get the design of it, the non-contact piece, the accuracy, the robustness of the device, and they see the benefits of that. And when we went to hospitals to talk about the thermometer, we thought that it would be used in more of the general wards and the routine wards like A&E. However, it was actually in the high-risk patient wards that we saw interest and uptake. And that was wards like your NICU, your PICU, your oncology, renal, and surgical. And it really was those wards that actually looked at it initially. And then when they saw the benefits from an infection control point of view, that they actually adopted it in their wards and their hospitals. And many of them have now been using it for over 3 years in that role. It isn't just a thermometer, a non-contact thermometer for use in screening at the door. It's used in every ward across hospitals in the NHS because of its infection control benefits. Because one of the metrics we heard quite a bit was that 80% of hospital-acquired infections were actually spread through contact. And therefore, if you take the contact away, then you take away that risk of spread. So that's really where the TriTemp was born, and with the help of nurses, especially infection control nurses, we then looked at how we could best make it for nurse use. So hopefully that answers the question, Andy.
Put my camera back. There we go. Yeah, so thank you for dropping in there. I just posted a question in the chat actually, just to ask generally what people have found to be their single most effective method of preventing and controlling HCAIs over the past year, especially sort of coming out of COVID. Have there been any sort of new practices that you've taken on? Any, obviously the existing ones of hand washing, but have you tried to reduce patient contact? Has Michael said about contacts that, spreading of diseases, but has there been a sort of new train of thought really that people have taken on board in the last year to 18 months post COVID? Although COVID is still out there, that general public perception is that we've moved on now to strep. But generally, if you can just post some answers there in the chat, we'll have a chat amongst ourselves on that one. But hopefully you found a little bit of interest there with the TriTemp. I will change my screensaver. It's gone over to my granddaughter now, so apologies for that one. But I'm going to ask Roisin a question. It's coming from me as a colleague. But how do you see medical device innovation facilitating infection prevention policies in the future, and that link between sustainability and innovation, and how that can help help hospitals and healthcare facilities move forward?
Well, one piece of the sort of puzzle here is that with a non-contact thermometer, there's no need for plastic consumables. And really, we have had reports and feedback from many nurses in different wards that have told us that they have found used plastics in the patient bed, on the patient food tray, and in the patient's locker and so on. And that's actually a huge risk of infection in itself. So as well as the non-contact piece for the thermometer, there's also the plastic, the contaminated plastic piece, and the issues there. Another thing, we had a chat with Michael this week, just before this call, this webinar, and he had talked about the waste disposal piece, and he mentioned it in his slide just before he got cut off the air.
Yeah.
Which was the infection control implications of the waste. And we know that many nurses spend their time not only going to find plastics, but then they have a requirement to dispose of contaminated plastics, which in many of the high-risk wards can be a huge issue for them. Just this week, I was visiting some hospitals in the US, in Florida, and I was in a 126-bed NICU, where there were a lot of very small babies, and a lot of procedures being performed in those babies, and a lot of kit that was used to monitor the babies. And in that ward, the nurses were using were using the contact form of thermometers, and they had suggested that they would prefer the non-contact because of that extra infection control benefit. Obviously, these are very high-risk patients, very small babies, and they want to put every element in place to help those babies, to basically remove risk from those babies. So there's huge implications, not just of the use of non-contact, but also the elimination, essentially, of contaminated plastic waste in a very high-risk ward, like these NICUs and the PICUs, and also the oncology wards and renal wards. So I think maybe that's something that we don't think about so much, but each plastic cap could potentially be a transmission risk. And I think Michael mentioned there the transmission-based precautions as well during his presentation.
Excellent, thank you, Roisin. So we've got the chat box there. We are still working hard to try and track Michael down. I'm hopefully nothing too major. He will be back with us pretty soon. With regard to the sort of contact aspect, somebody mentioned an outbreak a while back from axilla thermometers in the Oxford region. I've actually sort of just found the paper and I was having a look. Have you had much? You are aware of it, Roisin, but do you know a bit more about it, maybe to share?
Yeah, I mean, this is a trial, and it's a published trial, so it's published in a peer-reviewed journal. And we spoke to the team in Oxford about this when it was published. But essentially, it was a high-risk ward, a neurology ward, and there was an outbreak of Candida auris on this ward.
Yeah.
And when they had to lock the ward down, they had, to my recollection, there were like 70 patients that were affected by this outbreak. And when they locked the ward down, they then did the usual tracing back of where the source of the contamination and the spread. And they were able to trace that back to the axilla thermometers that were being used in that ward, down to the very strain of the bug. So, you know, it's one thing that we hear a lot from the hospitals is it's the high volume routine use devices that are basically can be causatory when it comes to this transmission based. And in that case, that was the root of the spread. There are other papers that are published out there, and you know we can make this available for anybody on the webinar afterwards if you want some citations on that, just of how routine use devices can actually be the cause of spread. And in a ward like that where it's high risk patients, then this is why we see the interest in the non-contact thermometers in these wards, because if they can take any risk out of the equation, then they will do it. So yeah, this is a published piece of information, so we can make that available. I think we might have located Michael.
I do believe we have.
Right. So I didn't get notified that I dropped out on my screen. Where did I get to in my presentation?
You've done the sort of 5-slide part, and you were saying it's like the initial slide there, Michael. So one where you were saying about the 5th slide, saying about saving money, bed space, etc. And then you were saying about like personal experience. So sorry about that. If you didn't get a notification, I do apologise. I sort of jumped in to try and not very well, I think, filled a space. Roisin, thank goodness, was here to bail me out. So other than asking questions, the next stage was going to be hand shadows and puppets. So if you are able to share again, if you go to your screen, I'll let you know and sort of go through. If I sort of do the mandatory next slide, please, until we're up to where you were.
Michael, it was the contact precautions, rapid precautions, and airborne precautions slide that you were on at the time when it dropped off.
Okay, I'm so sorry about that.
Not your fault at all. Technology is wonderful when it works, but
just there's quite a few more people have come on, Andy, isn't that right? So
here we go.
maybe it's just as well, Michael, more people can hear them.
Okay, so where had I got to?
You've done that one, and I think you were just starting the next one. There we go. Yeah, that's roughly where we were. So I'm going to sit down and de-camera myself now.
Okay. So I hope if it does run out, you've got my mobile number, Andy. Please call me if it does drop out, because I didn't get a notification. So the aim of today is to have a short presentation and then a question and answer discussion. To facilitate that, I'm now going to do a brief presentation covering some quite basic aspects of infection prevention. These are standard and transmission-based precautions, antimicrobial resistance, and the environment. And when I talk about the environment, I'm also going to be talking about medical devices. So people still get confused with terminology. And if people or healthcare staff are confused about this, then care may not be provided that is evidence-based, safe, and effective. It's really easy, however, to understand the difference between standard precautions and transmission-based precautions. Of course, it is COVID that's really made us more aware of the difference, but it's easy. Standard precautions are used routinely for every patient. Transmission-based precautions are used for a specific infection or infectious agent based on its route of transmission. So what are standard precautions? Well, as I said, they are things we do routinely for every patient as required. I'm not going to go into great detail about each one of these because I'm hopeful that you're well aware of them and how to put them into practice through the education you would have received. Many people say hand hygiene is the most important. I agree, mainly because we will need to do it for every client we see, but also because it has been proven that the hands of health waste disposal and patient care equipment. Transmission-based precautions are different because these are things that we do for specific scenarios. They are split between contact precautions, droplet precautions, and airborne precautions. These are additional to standard precautions. So contact precautions are used to prevent and control infections that spread via direct contact with a patient or individually from a patient's environment, including equipment. For example, MRSA and hepatitis A. Droplet precautions are measures to prevent and control infections spread over short distances, such as 1 meter, via droplets from the respiratory tract of an individual directly onto another individual or into their respiratory system. For example, influenza and rubella. Airborne transmission are measures to prevent spread from aerosols from the respiratory tract of one individual to another. These are smaller and travel further than 1 meter. For example, open TB and chickenpox. The CDC have produced some useful signs which you can see here, and I know many organisations that use these. I'm now going to briefly talk about antimicrobial resistance. So antimicrobial resistance occurs when bacteria, viruses, fungi and parasites change over time and no longer respond to medicines, making infections harder to treat, increasing the risk of disease spread, severe illness and death. I think Andy's calling me. Am I still on the call?
Yeah, you're still on, Michael.
I'm still on. Okay, thank you.
Yeah, you were. Sorry, Michael, it's my fault. I dialed inadvertently.
Oh, okay. So antimicrobial resistance it can be natural. So some organisms are naturally resistant to the antimicrobials that we have, but some have also developed antimicrobial resistance, and they're quite clever. They can pass information on from one organism to another. I could talk for a long time on antimicrobial resistance. You know, some people do a PhD on it. So what I'm talking about here are the very basics. The World Health Organization has declared that antimicrobial resistance is one of the top 10 global public health threats facing humanity. So what is it that's contributed to antimicrobial resistance? Well, resistance is a natural biological phenomenon, but it has increased and accelerated by various factors. So as I've said, some organisms are naturally resistant to the antimicrobials that we have, but misuse and overuse of antimicrobials are the main drivers for the development of drug-resistant pathogens. Now, I'm not just talking about healthcare here. I'm also talking about veterinary medicine, horticulture, and aquaculture. All of these use a huge amount of antimicrobials, and the overuse of these outside of healthcare has also contributed to the development of antimicrobial resistance. Poor infection prevention or poor infection control, allowing resistant organisms to spread, has also contributed to antimicrobial resistance. The use of more antibiotics to treat resistant strains has been required, and of course, the more we use, the more we lose. There has been a lack of awareness and a lack of knowledge around antimicrobial resistance, particularly worldwide and particularly in third world countries, where antibiotics can actually be purchased over the counter. There's also a lack of development of new drugs, meaning that we are actually losing the amount of antimicrobials we have to treat infections. So especially alarming is the rapid global spread of multi and pan-resistant bacteria, and we call these superbugs. We used to call MRSA a superbug, but actually there are some much more harmful bugs out there that are not treatable with existing antimicrobial medicines, such as some antibiotics. So local action is really important. It's really important organisations have an antibiotic policy outlining what antibiotics can be used within those organisations. Antimicrobial stewardship is really important. So organisations need to be making sure that they are prescribing appropriate antibiotics for an appropriate amount of time. And so they have people going around monitoring the use of antibiotics. And a lot of organisations have employed antibiotic pharmacists for that purpose. Global action, however, is even more important. There are some monitoring systems and some educational programs that have been set up in sub-Saharan Africa and Asia. There's a lot of research going on around antimicrobial resistance, and there's also a call for the development of more antimicrobials. And the UK actually has a special envoy on antimicrobial resistance, and this is Dame Sally Davies. The impact of antimicrobial resistance in healthcare is huge. Infections can be difficult to treat, and actually some infections are nearly impossible to treat. There may be only 1 or 2 antibiotics left to treat some resistant organisms. This means that more patients require isolation. So this means that appropriate healthcare facilities need to be made to be able to isolate patients. Organ transplantations and cancer patients need antibiotics to prevent and treat bacterial infections that can follow treatment. So these particular patients are much more prone to developing infections, and they need to be able to have antibiotics to treat those infections that you or I would probably be able to fight off ourselves. So without effective antibiotics, even minor surgery and routine operations could become high-risk procedures if infections can't be treated. And this is because some people will develop infections despite our best efforts. And we want to be able to treat those infections that may occur after surgery in particular. I'm now going to talk to you about the environment. And the built environment is extremely important. But it's not all about the fabric of the building. When I talk about the environment, I also talk about medical devices and equipment. However, the built environment is an extremely important factor, and it's really important that a built environment, such as a hospital or a healthcare facility, is appropriately built for healthcare services. So what I'm talking about that is that it's got appropriate number of sinks, it's got a sluice, it's got segregation of clean and dirty equipment, and it's got appropriate air handling units. And for this, infection prevention teams must be consulted for new builds and refurbishments. Infection prevention teams are trained to look at plans and to have an understanding of how a patient flow through a particular area will work and minimize the risk of transmission of infection. As I mentioned, air handling systems are now having a much greater focus, particularly because of COVID. There were some examples of COVID being spread from one ward to another ward because air handling systems pumped air through hospitals from one ward area directly into another area, recirculating the air. So there's much more of a greater focus now on air handling systems. However, as I said, it is not all about the fabric of the building, and the environment includes medical devices and equipment. So again, infection prevention teams should be consulted on the purchase of medical devices. And this is because they need to think about whether they can be decontaminated appropriately. I have seen in the past a huge amount of money spent on a particular medical device that a particular department wanted, only for it then to be purchased and installed for them to realise that they don't have the facilities to decontaminate it appropriately. And so it's really important that infection prevention teams are consulted on their purchase so that they can advise on how they should be decontaminated. There was a move towards more single-use items, and we're now sort of thinking about whether this is sustainable. This move towards more single-use items was because of CJD, but we're now starting to see more reusable medical devices come in where they're decontaminated and large decontamination plants are being set up. Reusable items must be decontaminated and cleaned between uses, and therefore it's important that staff are trained in how to decontaminate and clean medical devices, but it's also important that they're giving the right facilities and right pieces of equipment to be able to clean them properly. And disposable equipment and parts must be disposed of appropriately after use. I'm sure you've all seen urine bottles standing on patients' tables or bedside cabinets. I'm sure you've all seen earpieces from thermometers that have just been left on patients' tables and sometimes even on their food trays at meal times. So I think it's really important that people think about disposing of equipment appropriately and straight away after use. So to conclude, apologies for the presentation being in two parts, but I hope I've given you a basic run through to generate discussion and questions. Hope you can see that good infection prevention is good for patients and patient outcomes. Remember to use standard precautions all the time and transmission-based precautions as required. Antimicrobial resistance is a worldwide issue and needs a coordinated approach. And the healthcare building needs to be fit for purpose and practice, and medical devices must be used appropriately and disposed of or decontaminated after use. So thank you for listening. We now have time for questions and discussion, so I'm going to hand you back over to Andy.
Let's put myself back on. Right. Okay, thank you very much, Michael. I know there were a few technical gremlins doing their jobs as you were speaking, but I found that really interesting and really informative, as did, I should think, everybody else. It is being recorded, and with Michael's permission, we'll share his slide deck with everybody as well, if that's okay. But some really, really great points there. There are some questions possibly coming through in the box, but I can't really see them. But you said there, one of the ones in the environmental aspect is the actual decontamination or cleaning of a device or whatever. I asked the question in the chat box about it. Do the infection control team get a copy of the actual IFU of a device when it's purchased? Or at what stage do the infection control get involved in the actual purchasing process, Michael?
So I think it's really important that infection control is represented in committees in hospitals where new device and proposals for new devices are actually brought. That way they can get in there right at the beginning, and then they'll be able to get hold of the manuals and the cleaning instructions to advise the organisation on that. Yeah. So that's where I think it should start. The infection control teams should absolutely be part of those committees where new equipment and suggestions are brought to.
And interesting, I mean, as a salesperson, that is something that I've always tried to do, because I try and incorporate as many stakeholders when we're discussing a product, because people have different objectives with something. But the key thing for you guys is it efficient? But can it be clean? Can it be decontaminated? Excuse me, my eyesight is not what it should be at the moment. But I believe, Danielle, you just said you don't actually get copies of your IFUs, where maybe that's something, talk to your EBME or a department about that. But I think that incorporation of infection control when bringing in a new device to market, or even updates to devices, is key. So thank you for that one, Michael.
Andy, can I just jump in there and ask a question?
Yes, of course, yeah.
I just see someone has put in the chat there that they don't get involved in some of the purchase agreements, but are involved in the device. So in that case, Michael, how would anybody who wants to have that input, how would they get that input to the right person? I know some of the hospitals have like a medical devices review panel. Maybe they're not all represented by infection control, but is there a way for them to try and implement that?
So procurement has changed a lot in hospitals. When I first went into infection prevention and control sort of 20 years ago, I had a lot of direct contact with reps. They would come into our hospital. They would often give talks at our link study days and to our teams about new devices that they have. And we, as infection prevention teams, would be making recommendations on carrying out trials of these pieces of equipment and looking at the effectiveness of them. But things have really changed, and a lot of that is to do with costs and time. And so a lot now goes through procurement departments, and infection prevention teams are not always involved at that sort of early stage. And I think that is a shame, because sometimes procurement teams can't always see the benefit of some of these, particularly if the costs are higher. They can't always see the benefit that may bring, for example, cost savings further along the line. And so I think it is about infection control teams pushing to work hand in hand with their procurement departments when these sort of things are brought to them.
There's a new sort of concept with regard to delivery of healthcare called value-based healthcare, and also there's the term value-based procurement that is coming in, new legislation coming in next year. So is this something that is widespread to your knowledge, and are people aware of this, that it is important to get? Part of that, of course, is the infection control piece and the quality of care for patients. Is this something that you're seeing more of?
So I'm certainly seeing more infection control teams working with their procurement departments and being involved in the evaluation of equipment. I'm also seeing more organisations that have protocols which require sign-off by infection control teams before new equipment is purchased, and evaluation of those. So they're things that I'm seeing, but not all of those things that you have discussed.
Maybe we could ask anyone who's on the webinar if they could post in the chat if they are involved with or they do discuss with procurement or not, just so that we get a sort of idea of what percentage are involved and which ones aren't. Because I know based healthcare is coming. Oh, there's one.
Sue has just said she's very, very involved, which is great to hear. And I think, unfortunately, you're probably the exception rather than the rule, Sue. But as I say, in my previous existences in sales, I had very, very close links to infection control, and that's how I came to know Michael, with the input infection control had into either maintaining a product coming into hospital or a new one being on board. But that continual support from the actual supplier to the hospital team, to the infection prevention team, supporting you. And you said there about the study days. When I was at Daniels, they were something we always took part in. And I think that helped build the relationship and trust between supplier and hospital. In the chat, maybe you guys can let us know if you still do your own independent study days, or if you're doing regional ones, and if they're still as prevalent as they used to be. And that sort of leads me to a question here that I thought of earlier on, and that's to what degree, if any, to what degree is infection prevention impacted by the overstretched healthcare systems, burnt out staff, and the cost restrictions that we're all working under? Do you find that that's actually becoming not necessarily a burden, but it's a real challenge?
So, yeah, I mean, I think it's a challenge for infection control teams, but it's also a challenge for staff on the ground. You know, I've talking about the importance of standard precautions, transmission-based precautions. All of these things take time. In order to provide good care and good practice, you need to have the time to think about what you're doing. You know, what have I just done? What am I going to do? You need to have time to decontaminate your hands, and all of these pressures with short-staffed and increased patient throughput will impact on practice. You know, no nurse, midwife, healthcare professional wants to do any harm to patients, but actually not. With those increased pressures, they're not always having the time to be able to perhaps do as well as they would like to do, and I think that's a real shame. Infection control teams as well, I know, are stretched, and providing education to the staff is difficult because staff are not being released for education as much as they used to. And Andy, I don't know whether you've seen the same sort of thing when you've been going around talking to teams.
I have indeed, and what some people regard as a basic bit of education, I actually really call it like customer support, and I hate to use the phrase customer when I'm talking about the NHS, but to me, you know, they are my customer. But staff support that we can give people, because you're getting ever evolving members of staff coming through. The education piece, you know, I'll go back to Daniel's, just how to put the lid on a sharps bin, but what goes into it with regard to the TriTemp, how to be able to take a temperature quickly, and things that look simple, but they just still need that support. The cleaning of a device, how that is as well. But I think from having almost like another pair of hands to help you get your message across, and we do a lot of now, like online video, QR code, so you can scan and pick up the information. And again, I hate the phrase 24/7, but it's constantly there. So we're looking at ways where we can help support the staff understand how to use a device, how to clean the device, and the pitfalls and the moving forward. But trying to get people to actually be able to be given the time to come and actually sit in a training session, even if it's 10 minutes, are very, very few and far between. And that 10 minutes could be the difference between a patient living or dying, who knows, you know, no matter how basic the product is, that little bit of education, if, you know, if we can support, but yeah, that eroding of that time has definitely gone. You know, I try and I've tried recently to almost station myself in a quiet spot of a department and just have it as a roll-in, drop-in as you throughout the day. And literally, I'm getting nurses come in ITU or NICU. They're running through with a cup of coffee because that's their little break. They're taking the time out. These people are dedicated, but the time for education and training just doesn't seem to be there. So I'm just going to peer over my glasses like a geography teacher again. And
there's a couple of people that said that their regional study days are running regularly, and local teaching is more ad hoc, but it looks like they're doing some sort of more focused training, which is really good.
Excellent. You know, so that's a great thing that's come. You know, if we can, as a company, if you are using a device or thinking of using it, the support we can give can help you with that training package and that rollout and everything like that. So that's really great.
Andy, I see in the chat there that Danielle has said that she's the local IPC teams, but procurement is central, and where the things get lost in translation, which we can all sort of align.
Yeah, again, from a personal point of view, that is very much the case, because especially now with the expansion from what's gone from a trust now into an ICS, and that expansion, that message getting lost in translation is going to probably get even more lost by the time it gets to where it needs to be. So again, as a supplier, whatever we can do to help you get a product or however you want to work, but to be able to build that linkage and understand that process from a supplier point of view or from a user point of view, it's getting harder and harder. And especially with something like we provide, which goes into every department in every aspect of a hospital, there's no sort of champion or there's no real direct point of contact. So we are reliant on building those relationships. But something I've learned from this really is, let's get back and really build that relationship with you guys about how we can help you. And you know, the work you do is phenomenal. So
Andy,
yeah.
Andy, just on that point, just for everyone's information, you know, we are preparing some proposals at IPS level. And so if there was an interest from the infection control teams in those sort of ICSs, that we could actually bring that to the proposal to get the infection control teams involved and get their input.
Brilliant. So just a couple of other little questions there, Michael, whilst we've got a little bit of time, slightly still infection control based, but are you aware of any specific actions really to prevent or to help prevent staff getting actually picking up a virus or a bug, you know, during these pandemic times, that things measured in place to protect the staff? You know, we've got hand washing to protect between patients, but what apart from the PPE, are there any other policies and actions in place?
So I think it's really important that good occupational health is provided. People often see occupational health as somewhere you go when you're newly employed, you know, that you have your occupational health screening and that's it. And then perhaps you see them if you've been off work for such a long period of time. But actually, they can be there to be used as a real good support. And then obviously there's a lot of talk at the moment about emotional support and psychological support that is required from staff. And the impact of COVID and the pandemic has really increased the need for sort of that psychological and emotional support. You know, a lot of people, particularly in some areas of hospitals, saw a lot of death and a lot of people dying that we wouldn't usually expect to die. So occupational health is really important. Employee assistant programs as well. A lot of organisations have those, and then people don't realise, and you can have access to counsellors and financial support and all of those things. So I think it's about a holistic approach to staff really, and not just about infection prevention. I mean, the other thing that could really help would be if policies didn't keep getting changed at government level. You know, we saw policies change in response to PPE that weren't able to be provided, and so they changed the guidance, you know, and those quick changes are really difficult for staff. And yeah, somebody's just mentioned occupational health support skincare when staff have allergies. People forget that, you know, if people have got sore hands and things, they can provide advice and equipment. So thanks, Annie, for mentioning that. But yeah, for me it's a holistic approach, and that holistic approach, you know, happy staff, happy workers, better care, etc.
Well, I think so, and let's face it, they say laughter is one of the best medicines. Okay, but you know, having had personal experience recently, my wife was in hospital for a while, and she said the staff were so stretched, but when they came to her to give her a drink, everything, they were just smiling, and she said so positive, and she couldn't speak highly enough of them. And it's a massive thank you to the staff that looked after her. And I'm sure sometimes you have to paint your smile on, guys, and go out there and do the work, but we're all very thankful to you for that. But I think, you know, reading that, what you're just saying and reading between the lines there, have a proactive working relationship with those guys, because yeah, as you say, you probably might run there if you've had a needle stick or you whatever, but you know, the conversations are there, so that's a great one. And just sort of a last one really, with now like strep A and eye strep or whatever coming through, which patients would you say are the most vulnerable at the present time?
So I think it's really important for everybody to remember that COVID hasn't gone away.
Yes. Yeah.
Because the general public seem to think that it has, and staff are sometimes battling with patients and visitors to get them to wear masks and things like that. For some hospitals have still got that in. So there are some vulnerable people still out there for COVID purposes. We have got the talk at the moment of Group A strep. Group A strep does cause problems every year, but this year we're seeing about twice the amount, and that's probably because the last couple of winters people haven't been circulating as much. Schools weren't open, and now they are. Unfortunately, Group A strep can be very serious, and there have been some deaths, about twice as many so far as we would usually expect. We've got, not really scientifically proven, but we've got a cold snap coming up, and people do want to stay away from other people and stay in a bit. So maybe it will slow it down. I just think it's the important thing really is general awareness among the population about what's going on to help.
I think so. And sorry, Roisin.
Someone just posted in the chat there, I think it was in response to your comment about the QR codes and the information available, and they asked, are these there to support the staff? So I just wanted to show this little card that we have with a QR code on, just in case you're not aware of what that is. So just up here, there's a QR code that you can just scan with your phone, and you'll get all the information necessary. So hopefully that answers the question from one of the attendees here.
Yeah, I mean, the other thing, Andy, is obviously the most vulnerable patients are the sickest patients, usually in intensive care and neonatal intensive care, and minimizing contact with them is really important, and I know one of your products does help with that.
It does indeed. And I think phrase I'm hearing more and more is patient comfort, patient dignity, an aspect like that, and not being woken up every 4 or 5 hours to have things prodded or poked in you. So no, that's fantastic. I'm aware of the time and aware of people's commitments, but I've just got one last question there, Michael, if I can going to do my teacher impression again, and that's, how often are infection control policies assessed, and do these assessments have much impact on policy reform?
So personally, I review my organisation's infection control policies on an annual basis, and I change them when national changes come up, and so they become out of date. But one thing I think important for people to know now, I don't believe it's been widely communicated, but there is a national infection control manual that has been produced by NHS England. And so I think people should have a look at that, and we should really start implementing that within our organisation so that everybody's working from the same basic set of policies. I mean, there will obviously be additional SOPs required for organisations that do specialists, but it would be really good if all organisations could get that national infection control manual from NHS England implemented.
Are you able to put a link to that, Michael, in the chat, or if you whiz it to me in an email, I'll share it amongst the people? Because actually saying that, I do recall, I can't remember which branch meeting I was at, but I remember Pat Catini talking about it. I think she's been involved with the actual production of it. So that, as you say, and interestingly, you used the phrase earlier on about going back to basics. Those basics are there, they're in a manual. Let's start sharing them. So that's absolutely fantastic. As I say, I'm conscious of people's time, and I noticed a few people have had to drop off for various reasons, but I think this has been an absolutely brilliant session. And Michael, I'd like to thank you so much for your input, Roisin for your input too, and hopefully we can carry on a dialogue. We can do this again sometime, but Michael, it's been an absolute pleasure, so thank you very much and very informative. To everybody that's joined, thank you so much. Great comments, great feedback, and hopefully we'll talk in the future. So thank you very much, everybody. Take care, enjoy the rest of the day, stay safe, and if I don't see any of you, have a happy Christmas and a happy New Year. Thank you.
Thank you.
Bye.